and keep things moving along and be cognizant of people's times. Okay, Paige, I'll give it one more minute here. I'll do a brief introduction and a couple housekeeping things, and I'll hand it over to you.
Sure thing.
Okay. All right. So it's noon hour. We're going to get started here. Welcome to today's presentation on neurological emergencies and pediatrics. I'm again Ryan Trudeau hosting this as the regional critical care educator for pediatrics out of London Health Sciences Center. Just looking at the attendance reports, we got a wide variety of professions, as well as it looks like we have some participants from New Brunswick again. So welcome to everybody. So I want to do a brief introduction today to Dr. Paige Burgess, who is going to be talking to us today. So Paige is from our PCCU at London Health Sciences Center. She did receive her medical degree from the University of Toronto before she pursued general pediatrics residency at the University of Calgary. She then went on to complete her fellowship in sorry, pediatric critical care at the University of Alberta before returning home to Ontario, where she's currently, as I said, the intensivist in the PCCU at London Health Sciences Center. Originally, she is from Harrison, sorry, and she has a deep appreciation for regional outreach, which is fantastic. And she's definitely passionate about expanding our access to pediatric critical care education. Outside of work, she keeps busy with her son, or her child. Yes, her son, sorry, Paige, who is a 4-year-old. And they definitely are busy at that age for sure. So just a couple housekeeping things before I hand it over to Paige. If you can, if you have any questions, try to reserve them to the end. We do have the Q&A feature that is active, so we would prefer if you use that rather than the chat. And you can come off a mute afterwards to ask Paige any questions. We just ask that you raise your hand so that we can call on you in the order of the hands. Beyond that, there is a attendance form that is in the chat if you can kindly fill that out for reporting needs. And then towards the end of the talk today, I will pop in a survey evaluation form that we would like to gather your feedback on the webinar. Without further ado, Paige, I'm going to hand it over to you.
Okay, thank you so much, Ryan, for that kind introduction. I'm really happy to be here. And like I said, having grown up in a very small town with limited access to healthcare resources, I do have a very deep appreciation and soft spot in my heart for regional outreach. So I'm very happy to be here today. Um, the topic that I'm going to be presenting on is neurologic emergencies, the most common emergencies that we see in our pediatric population. Specifically, we'll talk a little bit about how to complete a good assessment for neurologic dysfunction. And then we'll talk about the two most common neurologic emergencies that I see and receive criticals for, specifically seizures and increased intracranial pressure. We'll talk about their differential diagnosis, some of the pathophys, and initial stabilization and preparation for transport for these patients. There's a couple of very special patient populations that I'll cover a little bit at the end, specifically patients with diabetic ketoacidosis, hyperammonemia, and sickle cell disease. And then, of course, we can open the floor up to questions, as Ryan had stated, and take this wherever you guys need it to go in terms of getting what you need out of today's session. So with that being said, we'll start with, I think, the most important part of today's talk, which is really going over how do we complete a comprehensive neurologic assessment when we have a patient presenting with a neurologic concern or suspicion for neurologic dysfunction. And really the unique thing about a lot of these neurologic emergencies is that there's really no blood test that we can do to assess the functioning of the brain. So we can test for kidney failure, we can test for liver failure, and we get great quantitative data back from the lab to either confirm or deny our suspicions of liver or kidney dysfunction, say, for example. But there is no blood test to test for neurologic dysfunction. So that is where we need to be really great detectives and do a thorough examination. And the most important part, I would say, of the CNS exam, from my point of view, when I'm getting a call about a critically ill child, is their level of consciousness. And the common language that we have to communicate this is our GCS, or Glasgow Coma Scale. You'll see that there are some variations to the Glasgow Coma Scale depending upon whether you're assessing a child or a nonverbal infant. But the three domains are eye-opening, your best verbal response, and then your best motor response. The lowest score that you can get is 3. The highest score, what you and I are right now, is 15, hopefully. But I think the big takeaway message that I've put here in big yellow letters is to be aggressive. So you will see that we have to look at our eye opening, our verbal response, and our motor response as the child is behaving spontaneously, to speech, and then to pain. And oftentimes, when we have a critically ill child, they're not going to be super responsive spontaneously or to speech. And that's where the pain component comes in. I know that we all are working in pediatrics because we love children and we want to protect children and keep them safe and comfortable. But this is really a part of our job when it is very important to be a little bit mean, be aggressive. There are many ways that you can elicit a deep pain stimulus for children. I have a couple of my favorite examples. So certainly you may recall things like an aggressive sternal rub, a aggressive trap squeeze. In terms of peripheral sensation, I like to take a pen and essentially press it onto the patient's nail bed as hard as I can press it to see if on all 4 limbs, if I'm getting a pain response. Another thing that you can do is take a credit card or your ID badge, place it at the base of the patient's nose and push upwards. This is extremely painful, extremely noxious. And if you don't get anything with that sort of a pain response or a pain stimulus, then you have I think, a very concerning exam that your intensivist on the other line is really going to be paying close attention to. So please do be aggressive when you're completing your Glasgow coma assessment. And like I said, this is really just a common language for us to communicate in terms of the degree of neurologic dysfunction or decreased level of consciousness. There are other parts of our neurologic assessment that are helpful for patients who are critically ill with neurologic dysfunction. Of course, our pupil assessment is important, and we'll talk about that a little bit later in more detail. And then we can talk about involuntary movements as well, specifically seizures, tremor, myoclonus, something to help quantify these movements or to better delineate them when you're communicating your exam is talking about, the frequency, the appearance, the amplitude of the movement, whether it's a fine tremor or more of a high amplitude jerking motion. And then, of course, if the movement is suppressible or not. Other parts of our neurologic exam sometimes don't really apply to our more unconscious patients, like our sensory exam and our coordination exam, but certainly deep tendon reflexes can also be assessed in even our unconscious patients. So that's the component of today's talk I wanted to highlight for our neurologic assessment. And now we'll talk a little bit about the first etiology that I wanted to cover, and that's seizures. So when we look at the definition of seizures, really when we strip down all of the fancy bells and whistles and trying to classify the different type of seizures, what we are left with at the bottom is that seizures are truly an abnormal electrical discharge of electricity in the brain. And depending upon where that electricity is initiating versus where it's spreading, that's when we get different types of seizure presentations. The differential diagnosis for seizures is quite vast. From an intensivist point of view, whenever I get a critical about seizure or a neurologic complaint, I always write this mnemonic on the top of my sheet to make sure that I cover everything that's important for me to touch on. And I use the mnemonic DIMS. So D for drugs, I for infection and inflammation, M for metabolic, and S for structural. And you can see here that I've listed different types of etiologies for seizures that would fall within each individual bucket. So for drugs, we can either think about drug intoxication or drug withdrawal. Specifically, if you have a child with an underlying epilepsy, missed doses of their anti-epileptic medications would also fit into this category. From an infection and inflammation standpoint, of course, there's infectious meningitis or encephalitis. We can also think about autoimmune encephalitis. For metabolic causes, hypoglycemia is going to be one of your most important considerations from a management point of view. And then, of course, there's always hyponatremia, hypercalcemia to consider. And then some of our more rare presentations, but again, important to think of is our children with hyperammonemia. And actually just recently we had a patient present in London here with a thyroid storm who initial presentation was for seizures. From a structural point of view, you can think about an undiagnosed brain tumor, hydrocephalus, a CVST or central venous sinus thrombosis. So again, a clot in the venous system of the brain. And then of course, either an ischemic or a hemorrhagic stroke can be triggers for seizures. Over here on the side, you'll see that I've made a brief mention of febrile seizures. I think it's important for us to talk about febrile seizures because this is such a common cause of seizures in the pediatric population. But I think with the lens that we're taking today from a critical care point of view, it's really important to highlight that febrile seizures are truly a diagnosis of exclusion, meaning that you have to be confident that you have ruled out all of the big, bad, and ugly causes of seizures before you feel comfortable seeing a patient in the emergency department saying, this was likely just a febrile seizure, go home and come back if you have any more concerns. So truly, you have to be comfortable that you've ruled everything else out. Now, does that mean that every patient that comes in with a seizure gets a CT of their head and a lumbar puncture and loads of blood work? Absolutely not. Many excellent pediatric emergency medicine colleagues looking at a well child with a normal neurologic exam who have had a short seizure can certainly, with their physical exam and clinical experience, feel confident in stating that a well-appearing child has likely had a febrile seizure, as opposed to going down the full $1 million workup for every single patient. So why are seizures then classified as a medical emergency or a neurologic emergency in pediatrics? And that's because seizures themselves can cause injury to our central nervous system. And there's a couple of different mechanisms by which this injury can happen. First, you can have a direct neuronal injury as a result of seizure. This usually happens in and around the 15 to 20 minute mark of continuous seizure activity, where your neurons are needing lots of energy and they have a high metabolic demand for releasing all of this electrical activity. And that can lead to metabolic burnout, meaning that they utilize all of the metabolic building blocks or the metabolic supply to the brain, leading to there being a relative deficit of energy to the remainder of the brain. There's also excitotoxicity itself. So just the firing of these neurons over and over and over and over again can induce direct neuronal injury. The second mechanism of CNS injury is really by way of a secondary injury. So by having uncontrolled electrical activity, seizure activity of the brain, there can be a secondary cerebral edema or raised ICP phenomenon develop. And then, as I mentioned before, by really burning all of that fuel or energy that's supplied to the brain, the metabolic building blocks, there can be that mismatch between metabolic supply and demand, leaving other areas of the brain relatively starved for energy, which again leads to a secondary injury. There's also systemic risks for uncontrolled seizure activity. I think first and foremost, we all think about and worry about respiratory drive and the need for airway protection when we have a patient presenting with status epilepticus. With ongoing seizure activity, there's also the catecholamine surge or storm that can occur, which can lead to rhabdomyolysis and multi-organ failure as well if left untreated. So you have a patient presenting with seizures. So how do we provide our initial stabilization? What are our initial steps? And like any other patient presenting with an acute concern, we always like to start with our ABCs. So airway, breathing, and circulation. If the patient is desaturating, give them some oxygen. If they're hypoventilating, you can support them with gentle bagging. Make sure that you're happy with their blood pressure and their peripheral perfusion. Now, as a step 2, I have here checking electrolytes and glucose. And this goes back to thinking through the differential diagnosis and recalling that hypoglycemia and hyponatremia, hypercalcemia can be causes of seizure. And we all know that our typical first-line treatment for seizures is benzodiazepine. But in patients that are having seizures secondary to hypoglycemia or other electrolyte derangements, we can give them all of the benzos that we want, but those seizures are going to be exceedingly hard to control if we don't actually address the root cause. So check your electrolytes, check your glucose. This can be done very quickly with a point of care glucometer or gas, and then we can intervene with correcting those abnormalities as needed. Step number 3, if your lights and your glucose all look okay, you know that our benzodiazepines are indicated at the 5-minute mark for our first dose. I just have here that we know that 92% of seizures are going to self-abort within 3 minutes of onset. So in 8% of the time, you will reach this threshold and benzos will be indicated. The other 92% of the time, you are truly just supporting their ABCs and you're checking for significant electrolyte or glucose abnormalities. So what about benzos? How much do we give and when do we give them? And I think that the most important things to consider about benzos are that we don't want to delay beyond that 5-minute mark. When we've crossed that threshold, we need to get them on board. And that has come out of a paper that was published in 2018 that looked into cases of refractory status epilepticus and divided them into 2 different groups. Those who had received their first dose of benzo in the first 10 minutes versus those who received them after or later than 10 minutes. And essentially, when we looked at the patient group that had received benzos after 10 minutes or longer of seizure, they had a higher odds of death, a longer seizure duration, and they also had a higher likelihood of needing 1 or more continuous infusion in order to control their seizures. And I suspect that this is likely related to the 4th outcome, which was a higher odds of hypotension. So when you reach that 5-minute mark, give your benzos, do not delay. The second important consideration for benzos is we shouldn't be afraid of giving the indicated dose right up front. So benzos, do not delay and do not underdose. Many times when I'm speaking with colleagues on the ward or in the periphery, when I'm speaking with my residents, there's always that concern in the back of everyone's mind that benzos are associated with respiratory depression. You have a patient that's seizing, maybe they're already needing some extra oxygen, maybe you're already supporting their respiratory status with some gentle bagging. And we become really concerned that giving benzos is only going to make that worse. But we know that actually the contrary is true. So respiratory depression is far more likely to occur with undertreatment and ongoing seizures rather than giving appropriately dosed and appropriately timed benzodiazepines. So at 5 minutes, please give that first dose of benzo and please give a full dose up front. Full doses are IV lorazepam, 0.1 milligrams per kilogram to a maximum of 4 milligrams. This by far is the preferred agent. However, if you do not have IV access, you should not delay your first dose of benzos in order to obtain IV access. This is when you would move to any of these 3 alternative agents, such as rectal diaz, intranasal or intramuscular midaz, or buccal midaz. And I have the doses and the maximum doses listed here. So we've talked a little bit about the first tier for management of status epilepticus. We've monitored, or we are monitoring our ABCs. We've checked our glucose and our electrolytes, and if they're abnormal, we've corrected them. And we've given a full dose of benzos at the 5-minute mark. If our patient is still seizing at the 10-minute mark, we can give a repeat dose of benzo. And the guidelines tell us that these first 2 doses of benzos are helpful, but repeating a 3rd or a 4th dose beyond that is not helpful. And that's because we know that at the 10-minute mark, our GABA receptors on our neurons start to internalize. So we're getting far less bang for our buck with additional doses of benzos in excess of those first 2 doses that are indicated. So you've given 2 doses of benzo, and unfortunately, your patient continues to seize. This is when we need to move to our second tier therapies. Our second tier therapies include IV antiepileptic loads. My favorite is Keppra. Keppra is very well tolerated. Keppra is the brand name. Levetiracetam is the generic name. But this medication is very, very well tolerated. And really the only significant contraindication that would be important to note for Keppra is if the patient had a previous hypersensitivity or allergic reaction to Keppra. Keppra can be given by IV push. The dose for loading in status epilepticus is 60 milligrams per kilogram, up to a maximum of 4,500 milligrams. If Keppra were not available, my second choice would be either IV or intramuscular phosphonatoin. This is given 20 milligrams per kilogram to a maximum of 1,500 milligrams. This is a cousin of IV phenytoin, which is a little bit trickier to give, a little bit more challenging from a nursing point of view. You need a filter in order to administer it. And if you don't have stable IV access, phenytoin is a vesicant and can cause significant extravasation injuries and skin and soft tissue burns. So by and large, I do try to keep to Keppra with phosphonatoin as a second choice if needed. Valproic acid is another option. The dose for loading is 40 milligrams per kilogram to a maximum of 3 grams. This medication it can be especially challenging if you have a patient with underlying liver dysfunction. It can lead to hyperammonemia, so something just to consider, which is why it falls to the lower end of my preference list. And then I have here phenobarbital at the bottom. You may recall that this is a medication where the evidence is primarily for our younger patients, specifically neonates. 20 milligrams per kilogram is this dose recommended in the CPS statement for status epilepticus management. However, I do have this highlighted in red, just given that we need to be careful about hypotension and respiratory depression with IV phenobarbital. So first tier we've worked through, and let's say now we have given our IV Keppra 60 milligrams per kilogram as our second tier therapy, and unfortunately our patient continues to seize. This is when we move over to our third tier. Third tier, I would consider adding a second tier agent on. And at this stage is really where we should start to not necessarily jump on intubating the child right away, but being prepared to provide airway support or potential intubation for airway protection. So certainly a consideration here. Hopefully by this time, you've contacted PCCU via Criticall, and our team has been dispatched to come and support. Really, once we get to third tier, if the second line agent hasn't aborted the seizure, this is where we really need to start to consider PCCU admission for continuous IV infusions, which are going to require a continuous EEG for titration purposes. When packing up these children and getting them ready for transport to PCCU, I cannot understate the value of clear documentation around the seizure semiology, its duration, the medications administered, and then the effect of those medications that you appreciated in your initial resuscitation. As our team is dispatched and on their way to pick up the child, we can also consider or anticipate potential complications that we might run into while on the road or in the air. With regard to airway and breathing, there's always that concern, specifically if the child's been bagged, that they may have some abdominal embarrassment, causing emesis, possible aspiration if they don't have an advanced airway. So thinking about inserting an NG and decompressing that stomach would be an important consideration. As we layer on more and more and more anti-epileptics, we know a side effect is sedation and hypoventilation. So we have to be prepared as well for airway obstruction and hypopnea. So having airway adjuncts such as an OPA and LMA, suction available is important. And then thinking about the medications that you might need in case you had to move somewhat urgently to intubate the child as well. From a circulation point of view, we know again that a side effect of many of these medications is going to be hypotension. So it's important to make sure that these children have adequate access. If you're able to get 2 peripheral IVs, that would be considered wonderful. And then having IV fluids ready for initial management of hypotension would also be very helpful. From a neurologic point of view, considering the potential for ongoing or repeat seizures is important, and having rescue medications or at least a plan of what your next load or treatment would be is also important. And then finally, contingency planning is really dependent upon the specific etiologies of your seizure. So for instance, if your child is presenting with hypoglycemia, talking through and making sure that we have high concentration dextrose containing fluids would be important for transport. So that really brings us to the end of what I wanted to cover for seizures and status epilepticus. And now I would like to move on to increased intracranial pressure. And it's really, I think, impossible to talk about increased intracranial pressure without kind of nerding out for a minute and talking a bit about the Monro-Kelly doctrine. So this is one of my favorite kind of principles in physiology. And essentially the Monro-Kelly doctrine is simple. I'm a simple person, and I think that's why I love it so much. But essentially the Monro-Kelly doctrine tells us that our skull is a fixed space. So think of it like a box. And the box, you can only hold so much in it before things start to overflow. So essentially, the Monro-Kelly doctrine is describing that relationship between how much you're jamming inside the box and how much pressure you need to actually push everything down so that you can close the lid. So recognizing that the cranium is a fixed space, adding more and more and more contents to the cranium or to the box will eventually cause increased pressure within the box. So you can see here on the right-hand side, in our normal cranium, we have brain tissue, we have cerebrospinal fluid, arterial blood, and venous blood. And then, say, unfortunately, there's an extra space-occupying lesion in our brain, say a brain tumor, that is expanding. There will be a compensated state at the beginning of the process, whereby some of our CSF will be pushed out, drained, right, decreased. So that fluid will be shifted into our spinal space. And part of our venous blood as well will be able to compensate by draining, okay? But eventually, in a decompensated state, that mass or space-occupying lesion has grown so significantly that we've really surpassed our regular abilities to compensate and to keep a steady intracranial pressure. So we can no longer squeeze out more CSF, and we can no longer displace more venous blood. So therefore, our pressure starts to increase inside our brain, or cranium, I should say. And this is really what this graph represents. As the volume goes up, initially we can compensate and we can keep our pressure relatively low. But there's a tipping point, and past this tipping point, more volume is going to exponentially increase the amount of pressure that we see inside our cranium. And why is this important? So here we have a picture showing what looks like an epidural hematoma. So a new space occupying lesion that's taking up extra space inside the cranium, and it's pushing on some of the brain tissue. And unfortunately, the brain has tried to compensate as best as it can with displacing some venous blood and some cerebrospinal fluid, but we've exceeded its capabilities. And now we're having tissue that's actually being herniated, and herniation can occur in many different areas. So you can have uncal, central, subfalcine, and then tonsillar herniation. And what happens is once you start to push tissue out and around these more rigid structures in the cranium, like the falx or part of the bone or the foramen magnum, once you start to push them out and around, they get choked, so to speak. So you start to compromise the ability of arterial blood to flow in and provide the oxygen and the nutrients that are necessary for homeostasis. And you also start to impede the ability for these areas of the brain to drain their venous blood. So you get backup and venous congestion, which again is not desirable. So when you cut off that pathway for blood to flow in and out of the brain, eventually the end process is going to be tissue ischemia and cell death, which is what we try to avoid and prevent every single day for every single organ system in the PCCU. So if we know that increased ICP can lead to tissue ischemia and death, preferentially, it'd be great if we could recognize this process early and intervene early before we start to see those shifting or ischemic areas of the brain herniating. So the really challenging part about increased intracranial pressure is that it's incredibly hard to detect early on in the process because the signs, as you can see on this list, are quite non-specific. So early signs of increased ICP, we're thinking about headache and irritability, vomiting and poor feeding, right? So think about all of the children that present with gastro or the flu, right? Essentially, all of these children would meet these two criteria. For smaller babies, thinking about a tense or bulging fontanelle. And then, of course, altered level of consciousness and cranial nerve 6 palsies are more later findings of high ICP. Cranial nerve 6 palsies look exactly like this, where you'll have inward deviation of the affected eye. And the reason why cranial nerve 6 is the first cranial nerve to typically be impacted in scenarios of high ICP is because it has the longest trajectory. It is the longest nerve after it exits the brainstem. So as it has a much further pathway to follow to its end organ, the lateral rectus, there's far more opportunity for that nerve to become pinched or impinged for us to then develop the deficit of the palsy. So those are early signs of increased intracranial pressure. The late findings that we want to try to avoid at all costs are things like Cushing's triad. So Cushing's triad is a combination of typically systolic hypertension, usually with a widened pulse pressure, bradycardia, and then irregular respirations. And essentially the way in which Cushing's triad comes about is that you have impaired blood flow to your brain. So your body is trying to compensate by jacking up your systolic blood pressure to drive more blood into that really tight space where the body is seeing a significant roadblock to blood flow because of the high pressure. So the body is trying to compensate or overcome that high intracranial pressure and push more arterial blood in to feed the brain. You then can get reflexic bradycardia. as a result of that significant hypertension. And then as the pressure becomes so significant in the cranium, you can start to have brainstem dysfunction as a result of the higher pressures and potential herniation. And as we all know, our brainstem is our center for respiratory regulation. And then, of course, with herniation, we talked a little bit about the pupillary changes that we can see with that. I know classically we think of a fixed and dilated pupil when we're thinking about herniation, but that is truly for our uncal herniations, where you can see here the fixed and dilated unilateral pupil as cranial nerve 3 is being impinged upon, and then our parasympathetic fibers are interrupted. That's what's causing our patient's left-sided fixed and dilated pupil. But you can see there's lots of other types of herniation that are just as undesirable, right? But aren't showing up as a fixed and dilated pupil. So subfalcine herniation can actually present with no pupillary changes. Central herniation can present with these kind of smaller or mid-sized fixed pupils. Or sorry, I should say the constricted pupils, whereas our tonsillar herniation is more our mid-sized fixed pupils. So certainly a good pupillary assessment to assess for size, symmetry, and reactivity is important and can give us good information regarding the location of potential increased pressure or herniation. Now, going back to my favorite mnemonic, DIMS, for causes of increased intracranial pressure, drugs is less likely, I would say, to be a common etiology for increased intracranial pressure. But certainly infection and inflammation can cause high ICP. Think if you have a big subdural abscess, or if you just have a really bad encephalitis leading to cerebral edema, that can certainly lead to high ICP. Metabolic causes, as we talked about with hyperammonemia, also thinking about our diabetic children presenting with diabetic ketoacidosis, who have that osmotic cerebral edema, can also present with high ICP. And then thinking through structural causes, I like to again just think about what are all of the things that naturally exist within the cranium. The venous blood, right? Thinking about a CVST. Arterial blood. Is there an aneurysm? Is there an arterial bleed or an arterial stroke that has now evolved to have some cerebral edema included as well? Is there a new mass, such as a tumor? Is the brain itself swollen? So cerebral edema, which we'll talk a little bit further about next. And then finally, thinking about our CSF. Is there a significant hydrocephalus? Now, I talked a little bit about on the previous slide how we can have increased intracranial pressure as a result of cerebral edema. We can also have increased intracranial pressure as a result of anything else on this list, right? Of a blood clot, of a bleed, of hydrocephalus, of a brain tumor. But interestingly, a lot of these other pathologies are going to converge, and somewhere along the disease pathway or trajectory, there may be a secondary cerebral edema that's also contributing to the higher ICP. So thinking about the specific pathophysiology of cerebral edema, there's multiple different mechanisms. First, we can have cytotoxic edema, which is a result of direct neuron injury and death. So think about, for instance, ischemic strokes or significant traumatic brain injuries, where just as if I would take a hammer and hit my thumb and my thumb would become edematous and swollen, the same thing has happened to your neurons after becoming ischemic, after suffering a TBI. You've had direct neuronal injury, which leads to swelling and neuronal death. The second primary cause of cerebral edema is vasogenic edema. And this is secondary to an injury that's been sustained to our blood-brain barrier. So you'll remember that we have very tight control under normal circumstances of our blood-brain barrier, where this is going to be a security guard that's going to prevent significant diffusion of different substances or fluids into the brain. And unfortunately, if this becomes disturbed, we can get lots of edema secondary to essentially the venous component leaking into the interstitium. Other mechanisms for cerebral edema to consider would be interstitial. So this would occur specifically in cases of high pressure hydrocephalus, where the pressure in the ventricular system has built up so significantly that you're truly just with the forces of hydrostatic pressure pushing that fluid across your ventricles and into your cerebrum. Second, which is what we're probably more familiar with rather, is osmotic cerebral edema. So this is classically going to occur in our patients with DKA, where our osmotic gradients are going to be so deranged, and then of course having rapid correction may result in extra fluids shifting over following those osmotic gradients. So when we have a patient with high ICP, whether it is secondary to a brain tumor or cerebral edema secondary to high ICP, or a stroke with secondary cerebral edema, the principles of our management are going to be the same. They're all going to be rooted in two important concepts, the first of which is our cerebral perfusion pressure. So our cerebral perfusion pressure, which can be abbreviated to CPP, is essentially describing the driving force behind blood coming out of your heart and into your cranium. So we take our mean arterial pressure generated by our left ventricle, and we subtract the pressure that is inside our cranium. And the difference is essentially the driving pressure of blood into our cranium. I've put a little asterisk here beside intracranial pressure, because we also have to consider that blood has to drain from the cranium as well. And if there's a significant barrier or pressure that is impeding the drainage of venous blood from the brain, this can almost overshadow the ICP and cause a decrease in our cerebral perfusion pressure. So if we have a particular concomitant pathophysiology that's causing a very high central venous pressure, let's say cardiac tamponade, thinking about our trauma patients, or a tension pneumothorax, it's important not to forget about our CVP and how that impacts our cerebral perfusion pressure. When we think about our cerebral perfusion pressure, so again, MAP minus our ICP for the majority of cases, it's important to target a CPP no lower than 40 millimeters of mercury. This is what is widely published in our Brain Injury and Brain Trauma Foundation guidelines. And I would say here that this is absolutely the bare minimum. So for younger patients, infants, I would certainly accept a CPP of 40 or greater. When we're talking about children, I would err on the side of targeting a little bit higher CPP, say over 50. And then when we're thinking about adolescents, I would be aiming for a CPP greater than 60. So typically 40 for infants, 50 for children, 60 for adolescents are my rough starting points. The second concept that is going to be informing our management of patients with high intracranial pressure is the concept of cerebral autoregulation. And this is really how our brain, under normal circumstances, is regulating our blood flow. So, for instance, we can say when I am fast asleep and my blood pressure is, let's say, 95 on 60, versus when I am out for a run and my blood pressure is 160 on 100, why is it that when I'm sleeping, I don't have an ischemic stroke? And why is it when I'm out for a run, I don't have a hemorrhagic stroke? And it's all thanks to cerebral autoregulation. So when I am sleeping and my blood pressure is low, my vessels in my brain are going to dilate to try to encourage extra blood flow to my brain. When I'm out for a run and my blood pressure is very high, my blood vessels in my brain are going to constrict to try to decrease the cerebral blood flow. And unfortunately, in our patients with injured or sick brains, unfortunately, sometimes we can see that their cerebral autoregulation mechanism is no longer intact. So they don't have this beautiful period where they're able, or range, I should say, of blood pressures, where they're able to maintain steady cerebral blood flow. Instead, we see a direct diagonal line here, where low blood pressure is equal to low blood flow and high blood pressure is equal to high blood flow in the brain. And we already talked about earlier how high amounts of blood flow in the brain that's injured and has high ICP is only going to contribute to further increases in ICP. And that low blood flow in the brain is unfortunately going to cause ischemia and cell death. So this concept of cerebral autoregulation is really important to understand when managing our brain injured patients, because we want to keep really tight controls of their blood pressure to make sure, again, that we're avoiding very high blood pressure and very low blood pressure. You'll also see that for these more complicated and critically unwell patients, our intensivists will often give targets for PaO2 and PaCO2 when we're talking on critical on the phone. And that's because we know that our PaO2 and our PaCO2 are also going to affect the amount of blood flow that we get to our brain. When we have a low PaO2, so we're very hypoxic, our blood vessels in our brain dilate and we get high cerebral blood flow to try to promote more oxygen delivery to the brain. And when we have a high PaCO2, the same happens. And a low PaCO2, our vessels are going to constrict and decrease our cerebral blood flow. And this is going to come into play when we talk a little bit about management around acute increases in intracranial pressure and potential herniation management. So I've tried here to summarize on one slide what our priorities are going to be in managing these injured patients, or these patients with very susceptible brains with high intracranial pressure. And as we talked about previously, the name of the game is to maintain our cerebral blood flow and perfusion pressure. And we can either do that by decreasing our ICP or our CVP, or increasing our mean arterial pressure again, because remember that our cerebral blood perfusion pressure is equal to our mean arterial pressure minus our ICP. So to keep our ICP under relatively acceptable control, we want to keep our head midline and the head of the bed elevated to promote venous drainage. We want to avoid hypoxemia again, because with hypoxemia, as I mentioned, unfortunately, you're going to have vasodilation of your cerebral vessels, which is going to increase your blood flow and increase your ICP. You're going to have relatively conservative CO2 targets. So typically we start for our TBI patients of 35 to 40. You want to try to calm the metabolic activity of the brain. So this is having very aggressive control of seizures, temperature, agitation, and pain. And then you want to make sure that your osmotic gradients are working in your favor. So having a relatively generous serum sodium target and using hyperosmolar therapies as needed. To preserve your CPP, on the other hand, as we mentioned, we can make sure that our map remains healthy or even drive our map to try to overcome a high intracranial pressure. So to do this, we can use fluids and we can use vasoactives. And then, of course, if we have concomitant pathophysiologies that are leading to a high CVP, we need to make sure that we're managing those. So being cautious with our vent pressures and aggressive treatment of things like pneumothorax or cardiac tamponade. And then their second role is to really avoid any secondary injuries. So whenever I have a patient come in with a brain injury, I always talk to the family and I always say, the initial injury has happened. And unfortunately, I can't take that away, right? I can't take back the car accident or the skiing accident. But what I can do is I can try to control every single variable that I can to give the area of the brain that is not yet damaged beyond salvageability, to give the area of the brain that is susceptible the best chance at recovery. And the two big things that are going to be our number one killers in traumatic brain injury, especially in high ICP, are hypoxemia and hypotension. So we know that that brain is susceptible. It needs oxygen and it needs blood flow in order to recover. We also want to avoid hypo or hyperglycemia, and again, looking at seizure and fever control, as well as controlling significant coagulopathy to avoid any secondary injuries as a result of thrombosis or bleeding. So if all of this comes to a head, and unfortunately it's looking like your patient has significant high intracranial pressure, and you've had those early warning signs, and now we're looking at the late signs of high ICP. You have Cushing's triad, you potentially have pupillary changes. What can you do in order to reverse a partial herniation? And really, we have 4 steps. So the first thing that you can do that is quick and easy is to elevate the head of the bed. Try to get the patient up, right, as much as they can tolerate, keeping the head straight or midline, again, to promote venous drainage. So you're trying to use gravity as your friend in this case. You're using this graph that we talked about earlier in terms of the relationship with cerebral blood flow and PaCO2. So you're hyperventilating the patient to try to drive down your PaCO2, which is going to constrict your blood vessels, which is going to decrease the amount of blood flow to the brain. This in turn should decrease your intracranial pressure, but it will come at a cost of decreased cerebral blood flow, which again highlights that this is not a long-term solution. This is truly your back is against the wall and you're just trying to prevent complete herniation and brain death. So I often recommend that if you have pupillary changes and you're hyperventilating, have someone holding open the eyelids so that you can titrate your hyperventilation to the point where you see those pupils come back to symmetric or reactive state. You can also use hyperosmolar therapy, which is again trying to use high concentration gradients to draw some of that free fluid out of the brain parenchyma itself. So using hypertonic saline, 3 to 5 mils per kilo, you can push that over 5 to 10 minutes, and or mannitol, either 0.5 to 1 gram per kilo. In my experience, I find that saline is easier to administer. Mannitol is a little bit more tricky. Again, you need a filter to administer it. And then you can also get a very significant post-osmotic diuresis with mannitol. So you want to make sure that you're keeping up with the fluid losses that the patient is having to avoid any significant deficits with your preload. And then finally, we need definitive management. So we need imaging plus or minus surgical decompression. So all of these efforts are really made in an attempt to get the patient to a scanner and potentially to an operating room for more definitive management. In terms of preparing for transport, so again, we chatted about documentation purposes. In the interest of time, I again just want to highlight the importance of making sure that you are avoiding a low cerebral perfusion pressure and you're avoiding hypoxia. So again, you want these patients well sedated so that they're not spiking their ICP by bucking against a ventilator. You want to make sure that you're ready to resuscitate them from a blood pressure standpoint and that you have a good airway. In terms of the special patient populations that I think would be important to cover, first would be the diabetic ketoacidosis patients. These patients are at risk of seizures and cerebral edema secondary to the osmotic forces at play. The important things to consider with these patients is that if you have a patient that you're managing with DKA that all of a sudden has a decrease in their level of consciousness, remember first and foremost that if you have them on insulin, they have a significant risk of hypoglycemia. So check a sugar. The other thing is that insulin is truly what is driving your fluid and osmotic shifts. So if you have a patient that is decompensating from a neurologic standpoint, it is totally reasonable to pause your insulin infusion, deal with the concerns for their level of consciousness, either with hypertonic saline, and then when you're restarting their insulin, starting it at a much lower or gentler rate for correction is very reasonable. Patients with diabetic ketoacidosis, we need to have a very high threshold to intubate these patients because there will be no way that a ventilator can be as effective in compensating for their medical or metabolic acidosis as they are able to intrinsically. With regard to sickle cell disease, these patients are at higher risk of having an ischemic stroke secondary to sickling in the brain vasculature itself. I know that we talked a lot about keeping the head of the bed up and the head midline for these patients with sick brains. But when we have a patient with sickle cell disease and a high likelihood of an ischemic stroke, keeping these patients flat to try to, again, just promote more arterial blood flow to that area of the brain that suffered an injury is important initially. We then want to make sure that we're trying to prevent or decrease the amount of sickling that's occurring in the patient. So making sure that we're avoiding hypoxemia, acidosis, that we're avoiding cold, and then managing pain and stress is also important. We can decrease our hemoglobin S, so our sickling hemoglobin, with either a blood transfusion or an exchange transfusion. And then finally, for our hyperammonemia population, these patients are at high risk for cerebral edema. If you have a patient with hyperammonemia secondary to acute liver failure, they're also at high risk of having intracranial hemorrhage or stroke as a result of the significant derangements in their coagulation profile. The important things for initial management of these patients is to avoid catabolism and to promote anabolism. So our hyperammonemia is secondary to protein breakdown. So we want to make sure that we're trying to turn off protein breakdown by giving them high glucose infusions and also some exogenous lipids as well. Of course, these patients with hyperammonemia to the point where they have cerebral edema, it's important that we are getting them to a tertiary care center to prepare for dialysis and more advanced level of care. So somehow I seem to have finished right on the 1 o'clock mark. So thank you so much for your attention. And I'm more than happy to take questions either here or feel free to reach out by email.
Okay, great. Thanks, Paige. That was awesome. Very informative for our region for sure. So if there are any questions, you can pop them into the Q&A or raise your hand and we can have you come off mute and ask Paige any questions that you may have. All right, so go ahead, Megan.
Hi, I'm a pediatrician in Sault Ste. Marie. That was great talk. I just had three kind of quick questions.
Mhm.
I've tried to look it up, but do you consider parents' home doses of benzos as counting towards the total benzos, like the two benzos? And whether or not you count the EMS dose. I feel like I usually count the EMS dosing, but the home doses of the parents, I never really know if we count that or not.
Yeah, that's a really good question. And I think it really depends on the child that you have in front of you and what the home dose is. So a lot of patients that we see with home doses often have not been adjusted for weight in eons. And I find that if they're significantly underdosed, then I don't count them. And if the child has decent respiratory drive and decent hemodynamic profile, then I would be far more likely to just completely discount it and count my first like true full dose of benzo as my first dose of benzo. EMS I find is I count their doses because they are far more on par with our typical dosing parameters.
Okay. That's kind of what I have been following, so that sounds great. And then I do have two other quick questions, if that's okay.
Yeah.
If like you were saying, just to like prepare, and I usually like the critical doctor or whoever would be walking us through like preparing transport meds for patients that would be seizing. If a patient has stopped seizing, and like with a second tier medication, we've given them Keppra, whatever, and then I'm preparing the patient for transport. Do you recommend like sending more benzos if they were to like have another seizure on transport, or like or sending other second tier medication, or both
Yeah.
probably?
So if they've already had their two doses of benzo and you've loaded them with second tier medications, then I would be sending other second tier medications.
Okay. Even though they've like stopped seizing and then it's been a bit like, what would you ever redose the benzos, or do you not redose it because it's been within 24 hours or
Yeah, usually I would say the 24-hour mark is when I
24
would
hours? Okay.
start to re-intervene with benzo.
Okay, great. And then for those of us in the community, if we're looking at starting a Midaz infusion, I feel like like usually at this point we're talking to you guys anyways, but what is like a good safe dose that if I can't get a hold of you guys before I'm starting it to start at for a Midaz infusion if I'm getting there?
Oh, that is an excellent question. So I have to admit, my my units that I trained in are
Okay.
very different from the units that we use here. So let me just look this up really
And
quickly so that I
that's totally
don't
fine
lie
too.
to you with the units.
No, I appreciate it. Thank you.
Okay, so starting at um, 0.1 to 0.2 mgs per kg per hour.
Okay, wonderful. Thank you.
Yeah.
Okay, awesome. Thanks, Megan. Are there any other questions? Uh, Crickets, I see. Okay, well, I'm popping into the chat a post-event survey if you could kindly complete that. I will also send it out via email once the recording is available for registration for those who weren't able to attend today or want to rewatch Paige's awesome presentation today. Um, so yeah, if you can complete that, because Paige would like to see have some feedback on her presentation, but I would say it was very excellent today, Paige.
Okay, thank you guys so much for having me. Really appreciate being here.
All right. So thanks everybody for joining us today. Stay tuned for the next announcements for our next webinar. Everybody enjoy the rest of your day. We'll talk soon.